So last but not least, this conference is titled Healing Together. So how do we heal? I think that this panel is really going to tell us and give us some examples of how we really do heal, talking about trauma-informed clinical and support services. So we have a great panel today. And I wanted to start off by just talking about the different types of trauma. This is the National Child Traumatic Stress Network's list of types of trauma, and there are many types of trauma that we've talked about today. Some of them require kind of specific and unique different ways of addressing, but there's a lot of commonalities between all the different types of trauma as well and how we address them. And Tony Eiten talked a little bit about the primary prevention, secondary prevention, and tertiary prevention. I think that we need all types of prevention. Primary prevention, really preventing children from ever getting exposed to any kind of traumatic events. Those are the well kids in the Vermont Family Network that was previously talked about today. Or secondary prevention, the kids that are at risk or maybe have experienced some mild trauma. And then, of course, tertiary prevention, those that already have been affected. But as we all know, our system really doesn't pay for prevention like it should. This says, I'm sorry, but your HMO will pay for a pound of cure, but not an ounce of prevention. But this is what it's all about. We need to really be preventing the trauma that we're seeing affecting the children and the families today. Many people say there's so many different types of trauma. It's overwhelming. It's inevitable. I've even heard people say, maybe we should give up on these kids and really focus someplace else. But I think we all know that it's not inevitable. We do know how to prevent trauma, and we know that there are programs that work, and that's what we want to talk about today on this panel. Another way to think about it is that we want children to have that optimal healthy developmental trajectory that the Center on Developing Child and Jack Shonkoff's group has talked about. It requires supporting relationships, stimulating experiences, health-promoting environments. It requires attending to the basic needs that families need, the basic needs that all families require. I think that we haven't talked enough about poverty. The fact that 44% of children in this country live in low-income families, and that 22% of children live in poverty in this country is really atrocious. But we need to make sure that we do have basic needs covered and supportive relationships, stimulating experiences, and health-promoting environments. We know that there probably are some critical periods. People talk a lot about early childhood, adolescence. I would say there probably should be stars all across this healthy developmental trajectory because we know that trauma has huge impact that can last a lifetime and into adulthood, and that these adversities are really impairing health and development. But what we need to do is really make sure that there are those supportive relationships, really make sure that there are new protective interventions that make sure that children are on that healthy developmental trajectory. And what we're talking about, and we've talked a lot about today, is resilience, the capacity to cope effectively with the internal stresses of a person's vulnerabilities and the external stresses of their environment. How do we make kids strong? How do we make them really Superman and really be able to deflect the trauma and the stresses that they're going to have? And I think it really means a web of services. And this is one depiction of really weaving a fabric of resilience. It's really talking about resilient youth having caring relationships, high expectations, meaningful participation for our children and youth. And that means in the home, in the school, with their peers, and in the community, and within this larger policy context. I think that we need this web of services that includes multiple settings, and multiple opportunities to reach kids and families. It needs to be multiple level, across home, school, community, and family. It needs to involve universal screening that we've heard a lot today, and really universal screening of ACEs and traumas that kids and families are experiencing. And I think it also requires some political will that we really have to address these issues if we want to have healthy children, families, and communities. So today we really have an outstanding panel to talk about some of these interventions, clinical and support interventions. We're going to be starting with Victor Garcia, who is the founding director of trauma services at Cincinnati Children's Hospital, a pediatric surgeon. And I asked all of our panel members, how do they deal with stress? They are all dealing with trauma, families that have been affected by trauma. How do they deal with stress? And for Victor, it's rowing. boat rowing, and meditation and the water that calms him. Following him will be Laurel Kiser, who is Associate Professor of Family-Informed Trauma Treatment Center at the University of Maryland. She's a psychologist, and for her, she de-stresses with yoga. And following Laurel will be Annette March-Grier. She's the president of Roberta's Place, a family grief support center. And she quickly said, she didn't even have to really think about this, she said, mind meditation, prayer, and gardening. And then Leana Wen, our new commissioner at the Baltimore City Health Department. We're happy to have her here in Baltimore to help us address this issue. And for her, it's dance. So if you have some questions about what kind of dance, we can ask you later. But really great panel, and we're starting with Victor.
Well, thank you, Tina, and thank you all for for actually staying, because I know the hour is late. I want to begin with my story, and I also want to share with you at least one of the sort of concerns that I have, and that I'm not here to talk about resiliency. As a surgeon, I find myself sort of, if something is not right, you cut it out and you do a good job, and the patient does well. My perspective is one that I'd like to put everyone here who is involved with social services, resilience, how do we deal with trauma and stress, totally out of business. And let me tell you why I say that. When I began my career in pediatric surgery, I can't tell you how far along that was, but when I began my career in pediatric surgery, the number one cause of death for children was, or still remains, trauma, but the number one tumor cause of death was Wilms tumor. And children were dying as a result of, despite best efforts. Today, Wilms tumor is actually 80 to 90% of those children are cured. As I looked at the sort of trend in violence in my community, I asked the question, not only how do we help children cope with cancer, those who can't be cured, I asked the more, to me, demanding question, how do we cure trauma? How do we stop the violence? How do we identify the root causes that actually perpetuate the cycle of trauma in communities of color? And I want to share with you then how that came about in my mind and in my experience. I was the founding director of the trauma program at Cincinnati Children's Hospital, and in that role, my capacity, I was in charge of not only treating children who came into the trauma service, okay, but also preventing the injury. And as a matter of fact, a condition of my accepting that responsibility was that I would need to have the resources in order to prevent trauma, injury. When I arrived at Cincinnati Children's Hospital in 1991, the number one cause of injury for children was motor vehicle crashes. Today, it's actually violence and homicides. But when dealing with motor vehicle crashes, we put together a program that actually was evidence-based. It identified why communities of color were not restraining their children appropriately. We worked with the community to develop a community-based program, and as a consequence of that, we actually have a nationally recognized Buckle Up for Life program that has been supported by Toyota, taken to about 10 other cities in the United States, and there's been an investment of about $8 million. It occurred to me, why can't we do the same thing then about violence, which is the leading cause of death for adolescents? Why can't we do the same thing for infant mortality? Cincinnati has the number one infant mortality rate in the state. Why can't we do that for all the other health disparities that disproportionately affects people of color in the most impoverished communities? And I decided that we can do that. If we applied evidence, and if we did something similar to what I'm going to describe to you and what we did with the Buckle Up for Life program, and that is use a systems approach. that looked at the community as a source of strength, and looked at the latent strengths within that community and tapped them and mobilized them, and created then a transformation in that neighborhood, a transformation of that ecosystem. It was over about a 12-year period that I saw a 300% increase in the number of children coming in. Some look like this. But it wasn't this child that died. This child lived, actually. This is a child who was shot twice in the abdomen. His abdomen was so swollen that after surgery we couldn't close him, and we had to put something over there. But he did live. He did live. But it was a child who actually did not live that shook me to my core. There was a 12-year-old that was shot in the chest. And you have to have the context that we are the number 3 children's hospital in the country. We are the number 1 trauma system in the United States. And despite all the efforts of the trauma service, the skills of my team, that child died. Now, that was not the first time that a child died as a result of injury. But I went out with my sort of refrain. You know what parents want to hear. We did everything we could. Your child was not in pain. But something told me that I did not do, we did not do, we as a society, as a healthcare system, are not doing what we can and should do in order to prevent that child from dying. The news said that it was an assailant, a drive-by shooting. What my evidence shows is that it was concentrated disadvantage and poverty disproportionately impacting communities of color. It was the system that killed that child, and which is killing children today. And if we could then put together the same kind of thinking that put a man on the moon, we could solve this in my lifetime and in your lifetime. As a result of that experience, I decided to go outside of just reading about surgery, and I decided to pursue what the evidence shows. And I engaged pundits and luminaries like William Julius Wilson. And you've heard this today, and I'm going to spin quickly through some of these slides because much of what I'm going to share with you, though it's already incorporated in my presentation, you know already. But I want to lead, again, to refresh the foundation here for what we needed to do. And by the way, my contention is I was not going to wait for policy. Sadly, our government is dysfunctional. But don't get me wrong, I love my country. I'm a graduate of the United States Military Academy, served 20 years in the military, but we are dysfunctional as it relates to things that truly matter. And we cannot wait until Congress decides to address inequality in the United States. We can't wait until our government decides to do something about racism. We can't wait until our policymakers decide to really address the root causes, and that is concentrated disadvantage perpetuated by poverty, joblessness, underemployment. We are just now pursuing a raise in the minimum wage. 1 out of every 4 jobs in the United States is a living wage job. We have significantly incapacitated a significant percentage of black males in the urban core by involvement with the criminal justice system so that they cannot have a job, even if they pursued one, as they do in many instances. Being poor and employed is different than being poor and jobless. And today's problems in the inner city have as their root cause joblessness, unemployment, underemployment. It's the cause of the crime that we see. You have to do what you got to do. It's the informal economy that people have to resort to because they cannot fill their rice bowls. They can't put clothes in the back of their children's back. It's the root cause of family dissolution in the female heads of households. Poor educational outcomes. We've heard that about the effect of poverty and stress on brain development. and fundamentally it's a consequence of the disappearance of work. It's well demonstrated that it leads then to the number of female heads of households that we have. And marriage rates are positively related to average male earnings or inversely related to male unemployment. But many of us, certainly the people that I speak with in Cincinnati, a much more conservative area of Ohio, don't understand that the poverty in the black community is orders of magnitude worse than the poverty of even some of the poorest white communities, as illustrated in this slide. And even though this depicts Chicago, it's also representative of many of the metropolitan areas in the United States. Did you know that those then who have production jobs over the course of the period of 1970 to 2009, that there's been a dramatic drop in both black and whites? But look at the proportion of blacks that now have. This deindustrialization of our economy has impacted the black community much worse than the white community. But look at the median net worth for a black male. In 1983, it was $6,400. 2010, despite the recovery from the Great Recession, it's $4,900 compared to a white male. It's concentrated poverty, persistent poverty that's intensifying. Now, the context that I was facing is that the chances of somebody living in a zip code of poverty, of getting out of that over a 10-year period of time, the chances of getting out of that, despite working hard, was 5.1%. Cincinnati was 82 out of 100. Thank God for Mississippi or Memphis or Atlanta. But earlier today we heard about some concerns about black males, as well as why poor women are having babies. The Fragile Family Studies helped inform me to understand and therefore to share with others who would be critical of, let's say, the behaviors of women in the black community, that there is a meaning-making and decision-making that we have to take account of. And similarly, the fact that men are not part of families now on an ongoing basis is really largely as a result of unemployment and poverty. So it occurred to me then that if we could address the socioeconomic status, that we could address all the things that we've discussed that really have consequences for children who I've spent my entire life helping. The other motivation for me is that socioeconomic status is the most powerful determinant of health outcomes. And many of you may be familiar with the Moving to Opportunity study, but it's clear now that living in concentrated poverty or escaping it can actually be some of the best efforts of improving health outcomes. Cincinnati has a 20-year life expectancy difference depending on what neighborhood you live. 20 years. In some cases, 6 blocks away. The neighborhood that Cincinnati Children's Hospital is in is Avondale. That has one of the highest mortality rates for both infant and adults. We've discussed already about the effect of adversity on brain development, but I want to illustrate here that despite these things being very effective, they are incremental in their effect, whether it's improved parenting or preschool or Head Start, etc. What was particularly sobering is the result of an Aspen report that suggested that despite community change initiatives being present for about 20 years, that their impact has been incremental at best. So to me, the answer as a surgeon is, well, we've just got to improve the socioeconomic status. We've got to improve employment opportunities. I was told I couldn't be done. You don't tell the surgeon that. Okay. So we started an organization called Core Change. Core Change then, and I don't have time to dwell on this, and perhaps we'll have time with the question and answer period, is that I recruited the likes of William Julius Wilson and other true students of the sociology within the urban core, urban economists as well as systems thinkers and systems change agents, people who do this work at the industry level as well as in the community level. And we aim then to provide systemic solutions at ending urban poverty and its effects, but doing it in a way that it involves the community with the extraordinary abilities of the systemic change process of mobilizing even the most marginalized individuals, those who would not attend those typical community councils. And thirdly, we wanted to then, part of this process, then actually engage those outside of the urban core who felt that this was not their problem. And the objective then is creating community wealth. And the way we went about doing that is actually starting a business. It's called Waterfields. And basically the opportunity of this business is to take from the rich and give to the poor. We grow microgreens. We sell these microgreens to all the boutique restaurants in the entire Cincinnati area, as well as shipping it out throughout a 3-state region. It is a profitable business, not a charitable business. It is a market-based strategy. It is scalable, which we're demonstrating. And it is located actually in the most impoverished neighborhood in Cincinnati. Intentionally hiring individuals who are hard to hire. We seek out men and women with criminal records. And we hire them, we pay them a living wage, and our partners are instrumental in making sure that they have free health care as part of this effort. So here's the high-level concept. We build, we sell, we grow. By the way, this is grown hydroponically, right? And why is hydroponically an important issue for today? Where does most of your produce come from? No offense, Tony, but it comes from California, Florida, Arizona. What is California struggling with right now? Water. How sustainable, then, is the price for this produce? Okay. Because the drought is not something that's just happenstance or it's just a short-term event. Right? Okay. As well, we have the carbon footprint that's coming in, okay, the cost for this produce to come in. So the high level is that we then have this product grown, okay, in areas of high economic potential. We then provide a living wage, and we then use high-margin products supplied by the businesses located in the core. And the concept here is we keep the wealth in the urban core, right? Keep the wealth in the urban core. Sell it to the rich, okay, but it's employing the poor. Good idea? All right. And then as part, the further part of this is that it's not just jobs, but we understand that there's a culture associated with generations of concentrated poverty. And with the systemic change process approach, we actually engage in collective dialogue and look at the other consequences. How do we address then the other issues that are a consequence of growing up in concentrated poverty? And this is the systemic change process, which I don't have an opportunity to elaborate on. But as a result of this, not only do we have meaningful, purposeful work in the urban core, but we also now have built capacity within the community. So in conclusion, I would argue that the key driver of the disparities that we're trying to cope with and develop resiliency for is poverty, unemployment, underemployment. Why not tackle that? And let's not wait then for government or policymakers or the latest nonprofit to emerge to address that. Okay? Who within your group then could identify then a business model or a business that would be located in the urban core? And by the way, one of the components of scaling this is that you leverage the procurement power of an anchor institution. We are sitting in an anchor institution. And this anchor institution then can be part of the solution of the root cause of the health disparities. Yes, Johns Hopkins may go out of business, okay, but wouldn't it be great, from a healthcare standpoint, patients not coming in? But wouldn't that be a good idea? Thank you.
Well, I appreciate everybody who is still here. I know it's been a long day. I'm Laurel Kaiser, and I know when I hear about big issues and big systems that sometimes it can get a little overwhelming. And so I'm going to bring us back to some basics and even think small and naturalistic. Let's talk a little bit about families and poverty. You've heard a lot about the intergenerational nature of trauma and the intergenerational nature of violence. And for me, the family is the basic unit around which our society operates. And I think that in trying to understand the impact of chronic, continuous trauma on families, we get some hints about what we might do to change things. And so this is a diagram that we use to explain the impact of trauma and poverty on family systems. And you'll see the white box, and I think maybe this is well, never mind. You'll see the white box, and that's our box which really describes the traumatic context of urban poverty. And what is contained within that context is multiple traumas, is high stress, and is all the secondary stressors and problems that occur related to trauma. The immense daily hassles that are related to living in urban poor communities. The incivilities that people have to deal with who are living in high urban poor contexts. And the other thing that is predominant about these situations is that there is a continued threat of unpredictability, uncontrollability, and continued threat and danger. So when we use terms like post-traumatic, there is nothing post-traumatic about living in urban poverty. It is continuous trauma, and it is that continuous sense of danger and threat that creates huge issues for families. And these lines on this diagram are empirically demonstrated impacts of urban poverty on every system and every subsystem within the family, and are related to outcomes in the family. For instance, in adult intimate partnerships, impacts such as the unintended pregnancy rates in families and the rates of conflicts and domestic violence in families living in poor urban contexts are related to that. And those effects spill over to effects on parenting and effects on sibling relationships. So we have a very dynamic, interacting system of impacts. We also know that, and I'm going to skip that because almost everyone has shown you this relationship, that the more traumas you experience, the worse the impact is. So we have been really looking at what it looks like when families have to adapt to urban poverty or multiple traumas. And so just like we look at, for instance, type 2 or type 3 trauma, which was described earlier, or a complex trauma at the individual level, we're looking at it at the level of the family and trying to describe the characteristics of what might happen for families to be able to survive generation after generation in urban poverty or in poverty and facing multiple traumas. And so you'll see there are disturbances at the family unit level, and they parallel a lot of the things that were talked about at the systemic level. So the system, actually, the family as a system, becomes a trauma-organized system. And a lot of the things that Dr. Berkowitz talked about are the same kinds of things you see at the family level. So you see disturbed relationships and supports within the family. You see an altered worldview. You see systemic dysregulation, where the family is supposed to be a unit that helps provide co-regulation for children growing up. The family system becomes dysregulated. And so you can see the parallels between what's happening. And obviously, the family is a place where a lot of this develops, and a family is also the place where a lot of this is passed down from generation to generation. And so the ultimate result of this is lapses or declines in family functioning. And what we see is these adaptations that the families make allow them to survive in the short term, but perpetuate generation after generation cycles of family processes that don't support resilience and healthy functioning. And so what can we do about that at a family level? Well, I've spent a number of years developing an intervention for building family resilience. It's most typically provided as a multifamily group intervention, so it's a social community that gets built around the families. But there are other models of it as well as a peer-to-peer intervention. And there is some evidence for it. There's evidence for feasibility, for tolerability. It's an intervention that families actually come to. So even in our communities with multi-problem families, we have families who are attending 11, 12, 13, 14 sessions in the multifamily group. And that's good. And there's also positive outcomes. The intervention really contains the core trauma elements, the core elements of trauma treatment. But in addition to that, it really looks at how can we build core skills in the family based on what they do normally to help with deliberateness. And if you're dealing with a context that has a lot of unpredictability and a lot of things that are not controllable, building deliberateness, those plans that families have stopped doing because in an unpredictable environment, plans don't make a lot of sense, right? But really helping them look at deliberateness as a strategy for maintaining healthy functioning. And those others are pretty common. So I'm going to talk to you a little bit about some of the ways we're doing this. And we're really using evidence-based but very simple strategies to help families do this. So what's one of them? We use family rituals and routines in much the way that Chris Blodgett talked about building rituals and routines in schools. But where do those start? They need to start in families. So what do? So we look at shared family meals. Many of our families have stopped sharing meals. But there is a broad literature about the health effects and the positive protective factors that go along with shared family meals. And in important dimensions such as risk-taking and things, and healthy functioning and preventing trauma. And how do we do it? It's not just how many times a family eats a meal. It's not what kind of food they put on the table. It's can they sit at the table and have a conversation? And it doesn't have to be a conversation about politics or world peace or any of those kind of big things. It can be a conversation that starts to build relationships again, share information, do planning. You know, what did you do today? What do we have to do tonight to be ready for tomorrow? Those kind of everyday conversations that allow families to function and to get things done. And that's really the important stuff, but it's also limiting distractions. So put away your cell phone. You know, those kind of little things. So we talk a lot about shared meals, and every group opens with a meal time, with families sitting at their own tables. We pay a lot of attention to telling family stories, so it's been interesting to hear about the oral culture and the narrative. Well, all families share stories, and sharing stories has happened for decades, forever. We have told stories, and they're typically oral histories of family. And they also have been shown, there's a wide literature showing that sharing family stories has lots of protective functions. Again, in terms of well-being, positive self-esteem, family functioning. So we help the families with telling stories. And we teach them some of those things that really get disrupted when trauma occurs, like perspective taking, like reflectivity, like co-regulation, like adding affect to stories. And we don't start with their trauma stories. They tell positive stories. They tell visioning stories. And we do lead them then to facilitating a family trauma narrative. And I think that this quote was from one of our little guys who was starting to tell his family narrative. And he said, "Are you ready to hear this? This is an ear breaker." But then the family was able to tell their story and do some healing around telling their story. And so we build storytelling skills and then use it therapeutically to help families. We do a lot on routines. And one of the things that happens with routines in poverty is that there are a lot of routines necessary to get things done, but they a lot of times lose value for families. And so we pay a lot of attention to how do families build routines? How do they build schedules? And then we do something else. We say, okay, that routine you just talked about doing, that's going to happen the way you planned it about twice, right? And then something's going to get in the way. So can you start anticipating what might get in the way and what you might do when that gets in the way? So we start having them do some anticipatory thinking and planning and some preventive coping. So we focus a lot on bedtime routines. One of the biggest issues in trauma are sleep problems. And again, there's a good deal of evidence that structured nighttime activities and bedtime routines help kids get a good night's sleep. And when kids get a good night's sleep, their behavior gets better. Their chemical functioning, their cortisol pattern, their cortisol release patterns become stabilized, and they get better. So we help them build nighttime routines. We build safety routines. We have families do a map of their neighborhood and identify places that are safe and not safe and build routines that increase parental involvement in keeping the family safe. I could give you examples, but the time says 0. We do a lot on trying to have the families build positive memories instead of traumatic memories. So we work with them a lot on fun, laughter, and enjoying spending time together, and building a memory bank of compensatory memories that help them not be stuck with the trauma memories, but start building some of those positive memories. And you can get more information at the SFCR website.
Good afternoon. I'm Annette March-Grier, president of Roberta's House and co-founder. I have a video that I'd like to first show.
I love my city. I have lived here all of my life. But I believe that the violence in this city and grief are directly connected. I saw how it was impacting the children, and we weren't talking about how they cope with their losses.
Chicken nuggets, french fries, tuna mustard, and a milkshake. My daddy ordered the same thing as me. My dad gone. He got killed.
My son's father, he was murdered. That bond, it was just a bond that a lot of kids don't have with their father. That was his best friend, his everything.
A child's grief can be very different from adults. They can easily lose their identity and their security in their grief. That shift can be very dangerous if there's no support systems there.
Dear Dad, since you have died, I've been feeling sad and lonely, frustrated, hurt. I miss you and I love you.
There you go. Write your feelings. How are you feeling today? We provide a safe place for children to recover after the death of someone close. Many families come here because of a homicide. They are contending with so much hurt.
Hello, how you doing? And what's your daddy's name?
Let's talk about your emotions. I was lonely sometimes, and I was sad sometimes.
Our volunteers help the children explore their feelings.
Why did you choose red?
I was angry when my dad passed away.
And talk about healthy ways of coping.
Get that anger out!
We teach our children that it's okay to cry. His brother died, so he's feeling really sad. We have to help take their pain and move it towards their passion. There's a lot of richness here in Baltimore. Yes, we have a lot of ills, but Baltimore has a lot of rich history and culture in it. I feel responsible for my community. Continue to dream. If you don't have a dream right now, find one. Children like Chiron, they're able to move beyond their loss and gain a sense of hope. Grief is not made to destroy us. It's made to transform us into new beings, stronger beings. We can help our young people be the beautiful people that they have been created to be.
Thank you. So Roberta's House is really an effort to mobilize the community to address its grief and loss. It was founded in 2009, and I kind of organically evolved in this, coming from a funeral service background and growing up as a small child in a funeral home, and also being a registered nurse and recognizing the impact of grief and how it was destroying our communities and our families and our children. So I'm going to just take a few minutes just to talk about what we do at Roberta's House. Our mission at Roberta's House is that we believe that all children and families suffering the death of a loved one should have support and a safe place to heal and recover. And we hope to also be the primary resource in the community addressing grief as a preventative public health service. And ultimately, our mission is that families who experience loss are able to transform their despair to hope and become healthy and ultimately create safer communities. One of our pledges at Roberta's House is I care for you, you care for me, and we care for each other, which is a very strong, positive motto that we begin with each program. Our core value is hope. We honor the memory of those who have died by offering opportunities to learn positive and empowering grief experiences. We are the listening presence of the community. We have over 300 volunteers that have been trained throughout our inception. And our goal is really to establish healthy relationships and support systems for our children in our communities. And so how do we achieve this mission? We increase public awareness and address the need of supporting children and families who are grieving a natural or traumatic death of a family member or a significant person. We don't talk about the deaths that our children are experiencing so much. When families come to Roberta's House, they're not just confronting one death, but oftentimes multiple deaths, 2 and 3 within the year. Our goal is also to provide a confidential setting to facilitate that emotional, physical, and spiritual healing for grieving children and families where grief can be expressed and experienced safely. Spirituality is also a very important component of the grief and mourning process. The awakenings that occur, the meanings behind the losses and the deaths we find are so important that aren't being shared or talked about. The sharing and freedom of expression through peer support and professional services that encourage healthy coping skills. Peer support, we found, can be so powerful in helping children and families identify with one another, hearing each other's stories, problem solving amongst each other. It is as important, I believe, as one-on-one therapy to be able, for individuals to be able to identify with each other. So that is also a strong component of our programs at Roberta's House. We encourage a nurturing, positive family support system. Oftentimes, families can't or don't even have the language on how to talk to their children about the death of dad or mom, the violence that has occurred within their communities. They oftentimes assume that children will just get over it and be okay, and that is so not true. And we can see the effects of all of the trauma because of the deaths. So giving the families, the adults that come to Roberta's House, one of our biggest programs is our family and children's program. We have exercises where we actually have them to interview one another on the death and the feelings associated with that and the fears associated with that. We also implement community outreach programs that offer grief intervention to our schools, human service providers, and organizations in the event of sudden and traumatic death. We're moving more into schools and implementing after-school good grief programs this coming year. So I encourage you, if you are in the schools, to please seek us if you have an interest there. We find that oftentimes teachers and social workers are inundated with so much of the grief around a death that they don't have the time and sometimes not even the skills. Let's be honest, as health professionals, how much time do we spend in grief and loss and death and dying? I know as a registered nurse, I had 1 week. So I'm sure, as most of you feel also, that you oftentimes are not equipped to handle the impact of death. We also offer educational training and technical assistance to community groups and organizations, and especially the churches right now who are now developing bereavement support ministries in their churches in order to address so much death in our communities. So how do we do this? Many of you may be aware of Kubler-Ross, but there is a little problem with Kubler-Ross's 5 stages of grief, because what it tries to do is to fit us into these defined boxes of stages that oftentimes we as human beings don't fit in these defined boxes. And so the models that we use at Roberta's House, one is William Wharton's, which is the 4 tasks of grief. And this is where we empower individuals to be contributors in their grief work and healing. By this, they have to work through the process of acknowledging the loss, embracing and experiencing the pain, which is oftentimes contrary to what society tells them to do. We often tell individuals to be strong, carry on, hurry up and get over it, hold it in, do whatever you can in order not to show your grief and pain. Here we help them to embrace this experience, this learning experience, and to express it. Adjust to the loss externally, internally, and spiritually. Mind, body, and spirit, all 3 parts, have to be addressed with our grief experiences. And finally, to relocate and reinvest, meaning relocation of the individual, the attachment that you had with the death of the person. As far as a relationship, that relationship never ends. It becomes a spiritual relationship that we carry on in life, and to be able to reinvest back into life. Also, we use Alan Walfeld's theory, which is the child's 6 essential needs when grieving. His approach is very much similar to William Wharton with the 4 tasks, but broken down just a little bit more, where the child needs to acknowledge the reality of the death. So here's an opportunity where children and families come together to tell what happened. How did you feel when you heard the news? What are some of your fears? What do you miss most? What do you miss least? There's also a need to approach the pain of the loss while being supported. We find that oftentimes children aren't given the voice to talk about their grief and pain in the presence of adults. We train our adults to listen non-judgmentally, to be empathetic, to co-journ with our children and families through their grief experience. They have a need to remember the person who has died. They also have to develop a new self-identity. We talk about a new normal. We will never return to the person who was before this death occurred or this trauma occurred in our lives. So now, this child who no longer has a parent, who no longer has a mother or father, has to sort of shift their identity and determine who they are and where they're rooted in. A spouse or who now loses a husband or a wife has to reclaim a new identity. Find meaning in what has happened. Oftentimes we don't give children and adults the space to identify the meanings that are associated with their losses and with their trauma. And if we don't give them that space, then oftentimes they become stuck in those maladaptive emotions or those feelings of anger and guilt and pain. We also allow them to experience a continued support for future years. We help adults and the parents and families recognize the importance to continue the grief work with their children and families, because at each milestone in this child's life, they're going to remember mom, they're going to remember dad. So grief attacks will occur all throughout life. It's like that scar that heals, but the scar remains, and the wound, the healing or the hurt should not remain as strong. So when we talk about grief, oftentimes, not oftentimes, but if you really want to look at trauma, we define trauma as grief unexpressed. Grief unexpressed. And Roberta's House makes every effort to give every child and individual that experiences a traumatic death to express themselves and to heal. And we also recognize that grief is a normal and necessary response to an injury caused by a significant loss. And it's the process of adjusting and working through those significant losses. What we also believe is that mourning is an essential part of getting through our trauma and healing. It is essential. It's the outward expression of grief. It's the key to healing. Mourning is that active part of our journey through healing. It allows wounds to heal. It's a series of spiritual awakenings born of the willingness to have an authentic encounter with the pain surrounding the loss. I encourage you that we have to take more time out to listen to the stories and to help children and families mourn their losses in order for them to grow. There's good grief. Good grief can be good because it's the process of open, active, communicative grief and mourning. Good grief and active mourning create conditions for a healthy integration of loss, and it also fosters good mental health. But then oftentimes grief can turn bad when it strays off course and it becomes complicated in mourning. It becomes complicated. And it becomes traumatic grief. Complicated grief has become a social health disparity. We've had so many multiple losses in our communities that we have to begin to help families and individuals unpack their losses. And oftentimes it's not the initiating trauma, but it's the lack of support that we give that our communities don't have. So Roberta's House provides several programs. As I conclude this now, we have 10 programs, and you can visit our website to find out more about these programs, from children to adults to survivors advocacy, where we now visit every survivor of a homicide within 24 to 48 hours of the homicide and case manage. We have our Good Grief programs within the schools. We have Charlie's Circle for moms who've experienced prenatal and infant loss. We have quilting. We have a Camp Erin where we take 60 kids away every summer for a 3-day adventure camp with 40 volunteers. Our volunteers must go 20 through 26 hours of training because oftentimes our volunteers come wounded themselves. And this is the great reciprocity program or reciprocal program that I could ever imagine, where volunteers and individuals who once come through the program come back to be volunteers to help the wounded. We have bereavement ministry programs and professional workshops. If you didn't get to watch the video, I do encourage you to go to our website. All of our programs are free. I'd like to thank the many foundations that continue to support our efforts in healing our community. And if there's anything more that we can do for you, please reach out to us. Thank you.
Good afternoon, everyone. So I realize that I'm your last speaker before the closing, before our mayor comes to give her remarks, and that you've all been sitting for a very long day. So if you need to throw things or go for a bathroom break while I talk, I totally understand the need to do that. But, you know, I've only been here for the last couple of hours listening to our various panelists, and I'll just tell you that I am struck by the number of times that I am nodding or clapping, or just feeling like I agree with everything that people have said. And also that I sense this incredible passion and energy and dedication by so many people in this room as we were talking about data or theory or practice and so many of the things that our various speakers have talked about. I don't have much to add to everything that's said, except I do want to add a couple of stories. I now work as the Commissioner of Health in our health department here in Baltimore City, but I'm trained as an emergency physician. And when I was in my medical training, I did something that actually has forever changed how I perceive trauma. And I'll tell you that I work as an emergency physician, so in the ER, we see a lot of trauma, a lot of vicarious trauma, as Dr. Garcia was talking about. But when I was in my medical training, I was, at the time, interested in HIV/AIDS, and specifically HIV/AIDS in Eastern Africa. And I went to work in Rwanda. This was about 8 or 10 years after the Rwandan genocide. And I heard this horrific story, which was that not only were many hundreds of thousands of people murdered during the genocide, but women were raped and infected with HIV as a way to slowly kill them. And there were many women who had HIV, but who were suffering silently because they were too afraid to even get tested for HIV. And the men who were the perpetrators were able to get access to antiretrovirals in prison. But these women, in part because they were too afraid to speak up, in part because the resources were not available, these women were suffering in silence. And so I went as this bright-eyed, bushy-tailed, medical trainee to try to address HIV/AIDS in Rwanda. And what I saw very quickly was it wasn't just HIV that we had to treat. And it wasn't even the other medical conditions that we had to treat, with access to food and access to other things that were causing illness in our women and in our children. It was the pervasive mental health concerns. Can you even imagine being in a community where everyone around you, you've seen people getting murdered in front of you every single day, where you've lost members of your family, or even if you didn't lose members of your family, where you were related to the perpetrators, where you were related to people who massacred others, and you have to live with that burden and that guilt throughout your life. That trauma permeated every aspect of the community. Safety net that we take for granted of living in a community where we feel safe from day to day, that was missing. And what permeated, even though the war was over, everyone was still living in a war zone. That's what I saw then. And in my practice in the ERs in Boston and DC and here in Baltimore City, I've seen exactly the same thing. That even if we're not living in an area where we're massacring each other, In some ways we are, and you've heard all about what happens with violence and families of people who've experienced violence. But it's also my patient, 8 years old, named Paul, who comes to the ER every single time with asthma exacerbation. And he comes basically every week, and every time we give him more and more inhalers, he misses school, his caregivers miss work, but he also reeks of cigarette smoke. And we ask him about, and his family, about why he smells of cigarette smoke. And his family, they don't smoke, but what happens is that they are homeless, and they go between various houses. They can't control who's smoking in these various places that they're at. They live in and out of this environment. We've heard about the problems with poverty and what happens when 1 out of every 3 families here in Baltimore City live in poverty. What kind of safety net do our children have then? And with Paul and so many other patients who we see in the ER, what kind of environment are they growing up in? And is it any wonder that 1 in 2 youth in a recent study here in Baltimore City have symptoms of post-traumatic stress disorder when they're living in an environment not dissimilar to many war zones around the world? Now, I would posit that one of our most significant public health challenges right here in Baltimore City is to treat trauma in the same way that we treat any other illness. A few weeks ago, I attended a conference that Reverend Hickman, who was here earlier, held called Why Women Cry. And the point of this conference was to speak about these unmentionable things like mental health and drug addiction and HIV and so many other things that we don't want to talk about and yet are so important to talk about. We have no problem now, and I'm glad that we don't have a problem now talking about high blood pressure and diabetes and heart disease and cancer. It's good that we talk about them. It's good that we have strategies to prevent, good that we have strategies to treat them. But why is it that we don't feel comfortable speaking about mental health in the same way? With substance addiction, about 1 in 10 people nationally who have a significant addiction are getting treatment for it. 1 in 10. For what other medical illness would we consider that statistic to be acceptable? Cancer? Would we say that, oh, you have cancer, you have a 1 in 10 chance of getting chemotherapy? Would we find that to be acceptable? No. And yet we don't talk about substance addiction in the same way that we talk about access to any other medical treatment. The same thing with mental health. A few weeks ago, I was meeting with a group of our youth here in Baltimore City. These are youth ranging from 8 to 16 years old. And I thought this was just a nice conversation. I wanted to engage them as we talked about the importance of engaging our community around what they think are the most important. And I'm glad that I asked the question of what is it that you, as the youth of our city, see as the most significant health concern? Because had I not asked that, and I just assumed, I might have thought it's these issues that we're so used to talking about, like STDs or smoking or whatever it is that we tell our youth to care about these issues. And you know what these 8, 10, 12-year-olds told me about was their number one concern, their number one health concern? They told me that it was mental health. And they didn't say it quite like, well, I think that you should focus on mental health. But they told me stories about watching their loved ones die in front of them. 8-year-olds saying that they don't see the purpose of living to age 15, 16, because everybody in their family, their cousins, their brothers, they all died before that age too. 10-year-olds who don't see the purpose of getting out of bed in the morning because their aunt, their grandma, their mom, they're all addicted to heroin, and they don't get out of bed in the morning. Families that got separated, kids who don't even know their parents, who suffer from such significant disenfranchisement and disengagement that they don't see the purpose of living from day to day. Mental health concerns, the unmentionables that it's time for us to talk about. So you heard about today all kinds of different solutions, and I embrace them all. I think that everything you've heard today, there's so much for us to do. But I'll just say that we need 3 things. The first and most important, and the most important thing for us right where we are right now is to talk about these unmentionables. You heard about universal screening, you heard about incorporating screening and testing and of all of this, these conversations into our consciousness. And all that is so important, but I would say even having these conversations, talking about why women cry, why our community cries, what is it that we struggle with every single day, even beginning these conversations is so important and is something that each of us can do today. Second thing, we talked about building resilience and we talked about regaining control and empowerment. But part of that is developing healthy role models. Some of the work that we do in the health department, for example, includes a program called Dating Matters, where we go to 12 local middle schools to teach about how to recognize unhealthy relationships, but also part of that is understanding what is a healthy relationship. We have programs about in conflict resolution to teach about what is the right way to resolve conflict. It's not to pull out your gun, it's not to raise your fist even, but what are the right things to do? How can we build these healthy relationships and healthy role modeling? And that's something that each of you in this room, each of us, I should say, can do today as well in our communities, wherever it is that we are. And the third thing that I would say that each of us can do right now is to recognize that what we're doing, all these things that we're talking about, is so hard. It is really hard for us to be not only addressing trauma in an individual level, which is already really difficult to talk about, but to address trauma in the community. These are extremely difficult issues to tackle. And that's why we cannot address it alone. You heard so many great examples about the need to engage the community in every single thing that we do. I would say it's not only the people who come to meetings, like all of you, which is really important, but also finding our community who may not come to meetings. Come find our youth, find our individuals who Dr. Eiten was lecturing to us in the health department earlier, and he was talking about these individuals in our community who have lost that spark in their eyes, who don't see the hope and don't see the need to get up in the mornings. These are the individuals that we have to engage. And I would say, as hard as it is to address trauma, it is far too important of a topic, far too pressing of an issue for every one of us, for us to ignore any longer. So I wish to end by saying that I'm excited to hear from our mayor, who I believe will be here shortly, to address all of us. We were speaking about the importance of political will, and our mayor is someone who has that political will and has committed her time and energy and capital to really addressing trauma here in our communities. And I just want to thank again Dr. Blum and Dr. Leaf and the organizers at the Urban Health Institute and here at Hopkins for organizing this really important, terrific event, for opening the lines of communication, for starting these really critical conversations. Thank you very much.
So the mayor is on her way, but that gives us a few minutes for some questions. So, any questions? You know, we had some questions for them.
Possible.
Is that a question?
Oh. So
We have some questions for them. Do you know where it was on here, but I don't know where it is now.
Maybe this would be for Laurel Kaiser to just elaborate.
Okay. So one question is, it would be interesting to hear about experiences, process, and lessons learned. Maybe Laurel, if you could talk a little bit more about some of the work that you've done and some experiences, process, and lessons learned.
One of the lessons is that there's no one size of intervention or strategy that fits every family or every community or every provider organization. So it's really necessary to have flexible strategies that are very engaging of input from communities and families in terms of what they want and need, and doing lots of that kind of work prior to going out and trying to do interventions. And I think the other part is that everyone has said is that it's slow work, and it takes some time for things to take and grow, but so I think we have to be patient with it, but sometimes with problems this big, sometimes problems that could be described as wicked problems, it's hard to have that patience and persistence, but I think that's what we need to do.
In our experience since our inception in 2009, I have to really say that I believe that education is essential to everyone, especially those who are going through trauma, to help them understand their responses to trauma, to help them understand and be a part of their planning. I think sometimes we overlook or ignore the fact that they need to learn and understand and to be informed about the effects of trauma. And I see just within the work of Roberta's House and doing our bereavement education that a light comes on with many of the adults realizing that they've been carrying this burden or this anger or this guilt for so many years, and it has not really served them. And they've been able to release some of these burdens and guilts and shames that they've held on that really someone else placed on them, another adult maybe in their lives, or someone else transferred that pain to them. And so I just think there's a great need for education, that as we're delivering care, that we should also educate.
Our first tenet in public health is that prevention is the best policy. And maybe a close second might be that we need to start as early as possible. One of the most depressing duties that I have in my job is to chair a committee that some of you, actually including Annette, are on, called the Child Fatality Review. And in this work, we review every case of every child who's died in Baltimore City. You can imagine how depressing this is. And perhaps an even more depressing part of this is almost as soon as we begin reviewing these records, we realize that we can predict, even way advanced, maybe they die at age 16, that maybe even looking at where this child was at age 2, at age 3, based on their family backgrounds, that they could have ended up where they were. So it's so critical for us to prevent trauma in the first place, but really to address as early, as young as we can.
So the question was lessons learned. Is that right? Lessons learned. One of the challenges that I faced, that we faced with core change, implementing that in Cincinnati, is that even though there are supporters now, early on, the nonprofits who were sort of providing social services were one of our strongest detractors. And the perception that they had is that there was a shrinking pie, and that they saw another initiative potentially vying for limited resources that they had. And that was troubling because, as a physician, I really believe that if we could really address the unemployment, concentrated unemployment in the neighborhoods, that we could in fact save lives. And it was somewhat unsettling, the fact that that was not shared by others. But the lesson is persistence. Never, ever give up. And on this issue, we are at a point now in Cincinnati where we do have the support of the nonprofits. We also have the support of the business community, and we have the support of the healthcare institutions that really stand to benefit not only from saving lives, but also their reputation, as being supposedly interested in improving child health.
Any last questions? So one of our assignments as a panel was to come up with a question to ask all of you to continue the conversation on Facebook or on Twitter. We thought we would think also about some pictures. So this is one picture of a gunshot wound where the young person actually had lost their leg from a gunshot wound, one of Dr. Garcia's patients, and just thinking about the physical and the psychological trauma of that situation. But also this picture of a child's drawing. And the question for all of you is, how do we address root causes and equip individuals with skills and coping mechanisms to learn and grow from their experiences? Please think about that and send us your thoughts, and hopefully we can continue this conversation. Really wanted to thank the panel for excellent.